Thank you so much for the opportunity to submit this video for the social impact pitch. My name is Pancheshnikov and I'm a fourth-year OBGYN resident at Yale New Haven Hospital and starting my Urogynecology fellowship at Johns Hopkins in July 2020. My public health work in the DR spans a decade. In the past 2 years, I founded the Urogynecology Global Health Initiative, affectionately called UGHI, to address pelvic floor dysfunction in the DR. PFD, which includes urinary incontinence, pelvic organ prolapse, and fistulas, negatively affect millions of women worldwide, especially in low and middle income countries. Yet 50 to 90% of women do not seek care due to barriers inhibiting them from discussing their reproductive organs and misconceptions about PFD being a normal or an untreatable consequence of pregnancy and aging. Moreover, the scarcity of local provider training further exacerbates the underdiagnosis and undertreatment of PFD in low and middle income countries. Global health surgical projects have become increasingly popular among high-income countries to address lack of access to surgical care in low-resource settings, with the added benefit of fighting physician burnout. However, the traditional arrive, operate, and leave model poses several ethical concerns, including lack of proper supervision of trainees, fragile power dynamics, absence of proper follow-up, and the missed opportunity for training local providers. To address this issue, a group of U.S. universities created the WAIT guidelines, with the goal of creating accountable and sustainable programs with mutual benefit to all parties. UGHI is a model based on the WAIT guidelines to address the lack of PFD training and research in the Dominican Republic. We work by mobilizing urogynecology expertise from high-income countries to implement a training curriculum for OB/GYN and urology residents in the DR, while using clinical and surgical trips to solidify practical learning, as well as provide free, high-quality, and long-term patient care. We have enrolled UGHI's first cohort, consisting of 30 highly motivated OB/GYN and urology residents. The pilot curriculum consists of an in-person intensive course with didactics and simulations, followed by online readings and assignments. 10 of the strongest participants are then invited to participate in the UGHI Surgical Initiative. For the past 2 years, under direct supervision from 2 urogynecology attendings from Yale, UGHI trainees have evaluated close to 200 patients with PFD, completed 75 vaginal surgeries, and seen patients for follow-up for 4 weeks, 6 months, and 1 year post-operatively. In order to focus on sustainability and collaboration, we establish robust partnerships with local health leadership, hospitals, organizations, and individuals who have a lot of Urogyn experience around the country. We do not have a continuous source of revenue and rely on a combination of voluntary work, high-income participant assumption of travel costs, grants and donations for surgical materials and equipment, and fundraising. As for our impact, patient outcomes are monitored through follow-up visits and validated pelvic floor dysfunction questionnaires. Physician trainee knowledge and clinical and surgical skills are monitored through the completion of modified, validated U.S. surgical competency assessment tools. Additionally, qualitative monitoring of UGHI program performance is conducted through the completion of anonymous surveys examining perceived strengths and weaknesses of the participants. Some of our main challenges and areas where we request guidance are sustainability. To continue UGHI's work and scale up, it is critical that we develop a reliable revenue stream and strengthen our local and international partnerships. How can UGHI synergize its efforts with institutions that are already doing free surgical intervention work and can benefit from UGHI's sustainable education model? As for our curriculum, we have developed a pilot curriculum and are hoping to continually improve it. What are effective examples of simulation-based surgical training in low-resource contexts? Additionally, in practice, we often have to deviate from the U.S. Standard of care. While local guidelines are lacking, do you have recommendations for adapting our curriculum to make it more relevant to local practice without sacrificing quality of care? And finally, evaluating trainee knowledge and skill acquisition is often challenging. We have the additional challenges of language and limited resources. What are some strategies that we could use to improve our current evaluation methods for trainees? And how can we then appropriately recognize and target weaker areas of our teaching and training methods? Thank you again so much for listening. We welcome any advice, feedback, mentorship. Thank you so much.